Dr. Baliga here. This podcast is on cultural competency in the doctor-patient relationship by an outstanding chapter written by Dr. Horace M DeLisser, MD, in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. Dr. DeLisser is a pulmonologist and critical care specialist and associate professor of medicine and Associate Dean for Diversity and Inclusion at the Perelman School of Medicine, University of Pennsylvania, Philadelphia. Dr. DeLisser is active in medical education. This has included serving as course director of the first year medical student course, and he is also the co-editor of the book Achieving Cultural Competency, a case-based approach to training health professionals. Start off with a case. Jacob Bowen is a 65-year-old patient with a right upper lobe mass that has been confirmed by bronchoscopy to be lung cancer. He is felt to be an appropriate candidate for surgery, but is declining surgery because he has heard that exposing a cancer to air during surgery will cause the cancer to spread. What would be the most appropriate initial response to the patient's refusal of surgery? A. Accept his refusal of the surgery. B. Explain the scientific basis of cancer metastasis. C. Ask the patient to tell you more about this belief. D. Assure him that the physician doing the surgery is very skilled. And E. Refer him for psychiatric evaluation. We'll discuss the answer at the end of the podcast. This podcast is first of a series of podcasts derived from this outstanding chapter by Dr. Horace DeLisser. A number of historical, political, demographic, and social trends have converged over the last 40 years to make the US much more culturally diverse in terms of race, ethnicity, English language proficiency, gender roles, openness about sexual identity and orientation, religious and spiritual expression, and beliefs about the causes of disease and the meaning of health. Elements of this wider societal diversity are mirrored in the physician workforce. For example, women now constitute 47% of medical students, and significant numbers of international medical graduates come each year to the US to practice medicine. This means that physicians are likely to routinely encounter patients who in one or more ways will be culturally different from them. These differences in culture between the patient and the physician are potentially quite important. They may be a source of distrust, fear, misunderstanding, and or miscommunication, which in turn often causes patient anger and dissatisfaction, factors that contribute to confusion about provider-recommended care, the basis for provider-patient conflict, and sources of physician frustration and impatience. As a result, the quality of health care experienced by the patient may be diminished and patient adherence may be reduced. Failure to account for the importance of cultural differences in the interactions between physicians and patients is a factor that likely contributes to the presence or persistence of health disparities in the US. Given these issues, cultural competency in the context of physician-patient interactions speaks to the ability to bridge differences in culture between the patient and the physician so as to provide respectful, compassionate, and effective care that results in good patient outcomes. Approached this way, cultural competency is seen as an issue of physician professionalism. Meaning of culture. In providing an understanding of the concept of culture, three things are emphasized. First, culture is not inherited. Instead, it is a pattern of learned values, beliefs, and behavior that are shared by a group. It thus includes language, styles of communication, practices, customs, and beliefs about the nature of roles and relationships. Second, although one may be dominant, each person belongs to more than one culture, which may not be national, racial, or ethnic, but may also include socioeconomic, religious, or professional affiliations. For physicians, professional affiliation is particularly pertinent as medicine has its own beliefs, views, expectations, and ways of communicating. Further, physicians are part of an educationally and economically privileged group. Finally, cultures are also not monolithic or homogeneous. A number of factors, including age, education, income, gender, foreign versus US born status, acculturation, assimilation, and immigrant status, all modify the manifestations or the features that define group membership. Further, in an open multicultural society such as the US, where there are multiple layers of cross-cultural interactions and influences, each cultural group is continuously changing and evolving. Culture should therefore be understood as a multidimensional, heterogeneous, and dynamic concept that goes beyond race and ethnicity to include socioeconomic status, age, gender, sexual orientation, and spirituality and religion. Also included in this is the recognition that Western medical understandings of causes and treatment of disease are not universally accepted. Therefore, the dimensions of culture include race, ethnicity, age, gender, spirituality or religion, alternative belief or practice, sexual orientation, and socioeconomic status. All these dimensions make culture dynamic, heterogeneous, and varied. Going back to the case, Jacob Bowen is a 65-year-old patient with a right upper lobe mass that has been confirmed by bronchoscopy to be lung cancer. He is felt to be an appropriate surgical candidate, but is declining surgery because he has heard that exposing cancer to air during surgery will cause the cancer to spread. What would be the most appropriate initial response to the patient's refusal of surgery? A. Accept his refusal of surgery. B. Explain the scientific basis of cancer metastasis. C. Ask the patient to tell you more about this belief. D. Assure him that the physician doing the surgery is very skilled. And E. Refer him for psychiatric evaluation. And the answer is 1C. Patients will bring to their interactions with physicians beliefs about the causes or treatments of their illnesses. This may either be personal or idiosyncratic or reflect wider lay or folk beliefs. An example of the latter is the belief that exposure of a lung cancer to air promotes the spread of the tumor and thus worsens outcome. Therefore, the initial response should be one that further explores the patient's refusal of surgery and the beliefs that underlie it. Subsequently, other issues such as current scientific understanding of how tumors spread and reassurance about the safety of the procedure may become a part of the discussion. And certainly after a full discussion with the physician, the patient has the right to decline potentially life-extending surgery. I'm reminded about Steve Jobs because he was diagnosed with a rare form of pancreatic cancer in 2003. He allegedly delayed surgery to remove the tumor, the recommended treatment, for 9 months. During that interim period, He attempted to treat his cancer with alternative medicine, including a special diet, according to news reports. Given the slow course of neuroendocrine tumors, his decision to delay his treatment may not have been as ill-advised as some have claimed. This podcast is derived from an outstanding chapter derived from Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It's authored by Dr. Horace DeLisser, MD, pulmonologist, critical care specialist, associate professor and associate dean for diversity and inclusion at the University of Pennsylvania Perelman School of Medicine, Philadelphia. In the next podcast, we will discuss key elements of cultural competency.